Okay, hello everyone. Welcome back to the next interview on the Retinal World Congress. With me are Marcelo Zas from Buenos Aires and Aleksandra and Rachitskaya from Cleveland, Ohio. Welcome. Nice to have you here, both.
Thank you for the invitation.
Great to be here.
And you both had a really interesting talk before on diabetic retinopathy and AMD. And I'd like to start with you, Aleksandra, interviewing the ASRS interviewer herself. Tell me about your study or what you presented on the port delivery system.
So I presented on the end of trial results for Archway. So Archway was the pivotal trial that looked at comparison of port delivery system for neovascular AMD compared to monthly ranibizumab. And what we looked at is data in terms of visual outcomes, which were non-inferior. We also looked at anatomic outcomes, which were very similar as well, and safety outcomes. We showed that when you look at port delivery system that is surgically implanted and refilled every 24 weeks, the visual and anatomic outcomes are comparable to monthly ranibizumab.
Yeah, those were nice results. I think up to 96 weeks, if I'm correct?
Correct. So after 96 weeks, all the patients who are in Archway actually roll over in something that's called a portal study, and they are followed for a longer period of time to look more at safety.
Okay. And talking about safety, is there something you can say about the conjunctival erosion? There are not a lot of complications, but it is possible. Is there any way to prevent or overcome conjunctival erosion?
I think there was a lot of learnings that happened through all the trials because, we had Ladder trial, Archway trial, and we have ongoing Pagoda trial, which is in DME. And so we're learning how to optimize the surgical outcomes. And I think conjunctival erosion was something that, and is something that is a concern. And so we learn how to do the surgery. And, it's hard to teach retina doctors how to do surgery, but there's particular steps both in the beginning when you open the conjunctiva in terms of exposure, in terms of undermining both stenons and conjunctiva, making sure you have nice exposure, positioning of the implant away from your radial incision, and also in terms of closure at the end. You really want to bring both conjunctiva and tenons up and close it nicely so you don't have any gaps. Yeah,
which can be a bit difficult because it's quite anteriorly in the pars plana, and sometimes, especially in older people, you might not have enough tenon space there.
Right, and so there's a lot of undermining that can be done, so you really are not taught, and you bring it nicely and it sits nicely, absolutely.
Interesting. Marcelo, do you have experience with this procedure?
Not yet in Argentina. We don't have it. We are making the clinical trial, but we don't have the experience. No. We hope to have it in the future, in the close future, but maybe next year or maybe in 2 years in Argentina.
Do you think there's a place for it in treating diabetic retinopathy or diabetic macular edema?
Hope so. We want to less the burden in the patients, so maybe we saw in the clinical trials of the anti-VEGF therapy that we have maybe 20% of the patients will have regression of diabetic retinopathy. So maybe this kind of devices we can show, we can find the same results. Yeah. We hope so.
Going back to your talk, one of the most important messages I think was don't wait for surgery too long. Surgery in proliferative diabetic retinopathy may be the first step you want to take. Tell me a bit about it.
Yes, when we were residents on maybe in the 90s during the beginning of the century, we don't have the drugs. Now we are in pharmacology area. We have a pharmacology vitreous cavity. So we have drugs. They're very sharp drugs. But instead of that, we have the technology. Our operation rooms are changing. We have 3D viewing. We have drugs. We have a multimodal image. So the message for the patient, or the message for the population, or the message for not specialists in retina, and we have to treat the patient before with drugs or with surgery. Early surgery gives us better results, better compliance, less cost for the patients, less burden of the anti-VEGF therapy. So we have to have early vitrectomy around the world. And all the colleagues we were there at the round table, we saw the same message. We have to operate the patients before an early vitrectomy.
Yes. And what are your thoughts about that, Aleksandra?
Well, I think you're absolutely right. With the introduction of anti-VEGF, we got so comfortable with injecting, and you just inject, and sometimes it's just a pattern, and sometimes pausing and thinking that maybe surgery would be better for this particular patient. So I think it's important to not just get onto this VEGF train and you just keep going.
Exactly. And obviously now with the technology, as we said before, technology in the operation rooms of ours, are better and better. So we have now 3D viewing, we have filter, we have illumination, chandeliers, we have my mayo technique, and that gives you more freedom in the vitreous cavity, better results, not only anatomical, also functional. We can peel the membranes, we can stay in the ILM, we can manage diabetic retinopathy better between 30 years ago or 20 years ago. Those guys give you the early vitrectomy.
Yeah. And you mentioned technology. What about our fluorescein angiography? I see all types of OCT, OCTAs, all kind of other imaging techniques coming by. Is there still a place for fluorescein angiography in the future?
I think it is. Fluorescein angiography is a great tool to classify the macroedema, to be focal or diffuse, to watch the capillary closure, and to maybe capillary closure is the biomarker of the ischemic of the retina, and obviously to find macro ischemia. Because if you have macro ischemia in fluorescein angiography, the treatment with the anti-VEGF will be less. OCTA is a great tool. I love OCTA, but we have no standard communication or no standard images to classify the patient, to have a flow chart. What can we do when we have one find in the OCTA? But I think the future is this OCTA, and fluorescein angiography will be changing in the next years.
Yeah. And what about in AMD? Do you think it's different in AMD, or do you share the same thoughts?
Well, I think I totally agree. I think in diabetic retinopathy, it's interesting because you can see the neovascularization, but you don't necessarily see the leakage. And so where, a lot of times we target our treatment based on leakage. In AMD, it's fascinating because you can see a choroidal neovascular membrane, but a lot of times we have choroidal neovascular membranes that are not exudative. So you have this other kind of, you actually identify more choroidal neovascular membranes that you might not need to treat. So it's interesting, to your point. OCTA is exciting, it's new, and we're still looking at applications. I don't think it's going to replace FA in diabetes for sure, but I think it's definitely something that can help us take care of our patients, and it's a non-invasive tool. It's easy
That's
to do.
That's the more important thing. It's not invasive. It's not allergic. There's no. You take a photograph easily, and you get more information in one shot.
Well, great. Thank you very much for sharing these insights. We could go on for a while, but we have to finish the interview. Thank you very much. Enjoy the rest of the meeting, and we'll speak again.
Okay. Thank you for the invitation. Always an honor.
Thank you.
You're welcome. Bye-bye.